that's a great question. Hopefully, you guys will figure this out. You know, I should have told you this beforehand, but Bruce's lecture actually covers everything you really need to know. So what I've done, this is the benefit of going second, is I actually will just show you a few slides that he showed you and say, these are the ones you really need to pay attention to. So there are a few people in the audience who have, as I tell my older patients, have voted in numerous presidential elections. So, you know, we always think about the good old days, right? So the good old days, and even as you can see at the pictures, the good old days of medicine, where things are very straightforward. And, you know, in IBD diagnosis, traditionally, disease activity is based on patient symptoms. And we talk about the Crohn's Disease Activity Index, the CDAI. This has no objective evidence of active or inactive IBD. In fact, you don't even have to prove the patient has IBD, and you may have seen some presenters who show a patient with a really high, which is bad, CDAI, and it turns out the person has IBS. There are a lot of subjective criteria. Patient global assessment, physician global assessment. Well, I got news for you. If you want to keep your patient in a clinical trial, okay, you're not going to give them a good physician global assessment because then they won't qualify for the agent. So keep that in mind. And you know, things were much simpler back then. Here were your management options: steroids, sulfasalazine, perhaps antibiotics, and C number one. Okay, so, and this is why the older physicians don't need to recertify for the boards, because they all know it all already. Exactly. So let's talk about the good old boys, and they all are boys of IBD. Burl Crohn, Joe Kersner, Dan present, right? Exactly. Burton Karlitz, Paul Rickerts, and even my direct mentor, Steve Hanauer. So these are the good old boys, and I believe David Sacker is in the audience here. Yes, Dr. David Sacker as well, too, and a few others of most honorable mention. But the point is that this is what they taught us. This is what we preach. You guys have seen the pyramids, right? And you see we have to climb the pyramids, the step-up therapy. This is how you treat patients. And what were the results? How well did it work? I mean, this is what it was like when we were coming out of fellowship. Well, look. Virtually all Crohn's patients relapsed. This is the cumulative probability of a relapse-free course. You notice the slide basically bottoms out. By 10 years out, virtually all patients relapsed. And most require one or more surgeries. So one surgery is the little blue boxes. I don't have a pointer up here, do I? Oh, whatever. I might, but I don't know what to do with it. It's greater than 2 surgeries of the triangles that they're raising. And then, so, you know, Bruce brought up a good point. What if you do send a patient to surgery, right? Lots of great Crohn's surgeons. Well, Crohn's disease comes back after surgery. Again, don't concentrate on the exact numbers here. You notice that the curve goes all the way up to the top. 70% of patients, you know, past 10 to 15 years out are going to have Crohn's disease return. Well, there are new sheriffs in the town. Okay, and notice that our pictures are in color. There are new exactly. There's new sheriffs in town, and you can forget everything you've learned up to this point, because now we're wiping the slate clean, and this is how we treat IBD in, what are we, 2017 still?
Almost 18.
So Bruce had some take-home messages that, if you take anything away from this lecture, certainly won't be what I'm saying, but it should be what he said. Risk stratify for your initial and your subsequent therapeutic choices. Treat to target with incorporation of objective outcomes, and there are elements of therapeutic drug monitoring that we can use. And he also taught us that in order to get the best results, you start effective therapy early. I think, you know, Steve Hanauer once said, why are we making our patients earn the truly effective therapies? We don't do that in other human diseases. So you've all hopefully seen this step up first top down, which is 10 years old, published 10 years ago, almost 10 years ago, 9 years ago, where patients with Crohn's who really hadn't been on anything were randomized to get a few courses of steroids, azathioprine, or methotrexate, and finally they earn Infliximab versus those who got Infliximab right off the bat with azathioprine. People are fond to point out that the people who got the Infliximab right away, the orange group, while at 14 and 26 and 52 weeks clearly were better than the step-up group, By the end of 2 years, they evened out, and they said, well, look, you didn't have to do it. Well, that's because a lot of the other patients ended up on infliximab. But also, what we're looking at is endoscopically, you scope these patients 2 years out, and the patients who started out with top-down therapy, 73% had complete endoscopic healing, 73% versus just 30% of those who we basically diddled around with. So your diddling days are over, okay? Infliximab, early use is most effective. This is a pediatric study. Barla knows it well. Look at the response and remission rates with infliximab in children who'd had disease for just 2 years. 88% response rates, remission rates nearly 60%. Holy cow, you should buy this drug, right? Their rates were 20% higher than in the adult trials. Adalimumab, I boxed out for you the early stuff. This is 2 years. The first 2 years, if you're on adalimumab in blue versus placebo, look how well you did. Starting infliximab and now adalimumab within 2 years of diagnosis, man, this is great data. Certolizumab within a year to two of data. Look at that, certolizumab data, and even the other agents too. So stop making your patients earn things, just give them what works, okay? Now, combination therapy has gotten a lot of attention at this meeting, which it should, and to make it clear that many of the people who talk on the podium have very complicated patients. So particularly this may be true for them, but combination therapy does give the highest success rates. Bruce already mentioned the SONIC trial. Patients who are randomized to azathioprine in orange did less well than people in infliximab in blue, but the combination patients did best, particularly with steroid-free remission and mucosal healing. Although what Bruce showed us very nicely is the reason why the patients with the combination did better, the ones who really did better, were ones who had good infliximab levels. So it turns out that it may not have been the therapeutic efficacy of azathioprine in addition to infliximab, but the fact that if you have good levels of infliximab, your results were good, and if you had crummy levels of infliximab, they were not good. And it is interesting, like you said, how we've kind of gone through and through the study and come up with, I think, some important information. Also, look at the upper right part of that slide. Anti-drug antibodies repeatedly in monotherapy with at least the anti-TNFs are in the 12 to 14% range, and with combination therapy in 1 to 3% range. And that's a big difference. If you see a lot of patients, that's a big difference. What about adalimumab? And by the way, I made these slides. I tell you the message in the slide, in the title. So even if you don't want to pay attention, just read the title of the slide, okay? If you have thiopurine with adalimumab, you have superior results. The people in blue got adalimumab with a thiopurine. The people in red did not. Notice the blue bars go higher than the red bars in induction on the left side and in maintenance on the right side. The combination did better. I don't know if it's also solely due to levels, although I guess we'll eventually find out. And people ask, well, how much of a thiopurine should I give? Should I give 50 milligrams? Should I give 75? Well, there is growing data that you actually want to be more therapeutic. Again, the title of your slide is all you need to know. Therapeutically dosed thiopurines do give the best results. Okay, patients shown here on the left-hand side with antibodies to infliximab had lower 6-TGN levels of 117, while those who are antibody negative are 193. And on the right-hand side, you see a correlation, basically, that the higher 6-thioguanine levels correlated with higher infliximab levels, so this trending as well, so too. So when do you start the immune modulators? Well, if you do them earlier, you actually may get superior results. This study looked at patients who are on immunomodulators at least 3 months prior to starting adalimumab, and you can see the top curve showed if they were on adalimumab, on azathioprine or 6-MP at least 3 months prior to starting adalimumab, I don't remember if methotrexate was included, they had much better outcomes than those who weren't. And flare rates were lower if they had therapeutic thioguanine levels. So especially if you have tougher patients, they've been through one of the biologics, going through number 2, maybe heading to number 3, at least for the TNFs, consider dosing your combination therapy therapeutically. Yes, the risks are slightly higher, but these aren't, the easy patients. You're already moving into the more difficult patients. So higher trough levels equals better outcomes. It seems to make sense, doesn't it? So if you dose by trough level, look on the left-hand side. Here's the positives. You get better response and remission rates, you get higher endoscopic healing rates, you get lower hospitalization rates, lower surgical rates, and there is cost-effective data too. What are the negatives of doing levels? Well, this slide is a little old. It says extremely expensive. Actually, some of the costs have come down with competition, the good old American way, right? That's what we are told, right? The American way is the best way, apparently. Trouble getting insurance coverage, that's been better too as some of the costs go down. You may know that one of the companies actually offers two free levels of their drug each year. If some of the people who give talks say every time they saw the patient they got another level, well, if you're going to do that, then you might get quite expensive. Initially, we had slow turnaround time. It's not very helpful when your turnaround time is 10 to 14 days when you're trying to make decisions. Now that's much faster in some labs. And there was questions about how can you interpret different results from different labs. I think it's helpful to know whether someone has a lot of drug, whether they have no drug, and whether they have antibodies. And so I wouldn't worry exactly about the numbers if you're really confused about the labs. So Bruce again, here's Bruce's picture, in case you don't see him sitting up here. He listed the minimally effective concentration for a few of the drugs, suggesting that you were shooting for Infliximab over 5 at trough and over 10 for fistula if you're having trouble. Adalimumab greater than 7.5, Vedolizumab around 20, but that's just week 6 data, and Ustekinumab early data greater than 4.5 at trough. I did see a question come in, what about going for higher and higher levels of Vedolizumab? I think it's hard to know. With that agent, perhaps if some of the other speakers have a different opinion, they can let us know. And now I have been writing letters to insurance about my fistula patients, suggesting that they need, with the study that Bruce showed, higher concentrations of Infliximab at least. And then trying something different. You know, a number of years ago when this conference first started, it was a short conference because we only had one biologic. Things were easier back then, but now we have lots of things, different families. And so what is a family? The mechanism is thought to be relatively similar, whether it's the anti-TNFs, the anti-adhesion molecules, or the anti-IL-12/23s. And it may just be that your patient needs a particular family of anti-inflammatories. And also therapeutically, if you're hitting a home run with one family, and then maybe the patient gets antibodies and no drug, you stick with that family as well too. Almost all the therapies that followed the anti-TNFs were studied in TNF failures, the ones that have been marketed and have made it out. And what we're trying to do is to personalize the medicine, and it's getting there. Wouldn't it be great if we could do a blood test or a stool test or something on the patient and know what is their pathway? Maybe a saliva test. Should we lead off with a TNF? Should we lead off with an anti-IL-12/23, an anti-IL-17, an adhesion molecule agent? IL-22 therapies are being looked at. There are lots of other therapies that I'm sure I'm not aware of that are being looked at. So ideally, and we would hope as we get the technology, we'd even be able to convince the insurers that they'd want this information to then help guide medicine, and then you could use the best customized agent. Bruce showed you this algorithm. I think you can save slides. You should save this slide and send it to yourself or whatever you can do with it, because this is really a great algorithm that I'm not going to reread today. Sorry to disappoint you all. But I think the best therapeutic approaches are using effective therapies early. You saw the pictures. I love all those people. I didn't know Burrow Crohn personally, but I didn't know the other. I love them dearly. However, it's time to move on. Use appropriate doses. It's so annoying when we see patients coming in sub-therapeutically dosed on the medicines. What do I do next? How about dosing them appropriately? Check levels, adjust the dose accordingly. Combination therapy, if you're not going to do it initially, which I'm not saying you have to, certainly considering adding it on, or if you've had patients who've already failed therapies, particularly if they've made antibodies. And think about changing therapeutic families. If you really have had no success in the anti-TNF family, move to the IL-23 family, in Crohn's at least, move to the adhesion molecule family in Crohn's or ulcerative colitis. Thank you very much.